بسم الله الرحمن الرحيم وعلى بركة الله نبدأ محاضرتنا لهذا اليوم. محاضرتنا لهذا اليوم is the orofacial pain. Again, I'm going to introduce myself to you. I'm Prof. Dr. Fawaz from the College of Dentistry, University of Baghdad. Our lecture today is considered to be as a very important. Important because we are going to differentiate between the different modalities of a treatment. It is important because we could know how we could differentiate between the different types of pain, and we could know whether the patient is complaining from neurological types of pain, whether the patient is complaining from vascular types of pain, whether the patient is complaining from atypical facial pain, and we are going to study the most important characteristic features of different modalities of treatment. And we try to differentiate in order we are going to know what is the sign or symptoms of the intracranial types of pain and which specialty is responsible about each type of pain for the patient that is attending to us. That is to say, whether we are going to send the patient for ENT specialist, whether we are going to send him for a neurosurgeon, because we consider these types of pain is considered to be as the intracranial lesion, whether it is a neurological types of pain, like for example the trigeminal neuralgia, the glossopharyngeal neuralgia, and so on. So the main aim of this lecture is to know, first of all, the characteristic features of each type of pain, knowing which type of pain is important and which specialty is responsible for diagnosis of the. So before we are going to know characteristic features of every types of pain that we are going to deal with, first of all, we have to know exactly what we mean by pain and what are the physiological aspects of the pain. Pain is a sensation of suffering resulting from noxious stimulation. Sometimes it may be associated with a physical disorder or mental derangement. It is considered to be as a unpleasant sensory and emotional experience, and mostly associated with actual or potential tissue damage. The most important physiological aspect of the pain involved nerve receptor stimulation is considered to be as transmission transduction modulation and central integration in the higher thought and emotional center. And finally, pain is considered to be as unpleasant sensory and emotional experience and associated with actual potential tissue damage. The acute pain resulting from injury will generally initiating a reflex withdrawal, thus ensuring minimum or no tissue damage. And there are a common terminology which is going to be used during the study of the pain. Eudynia, which is considered to be as the most important in the terminology of the pain, and here the injured region became sensitive to even a light touch. So it is referred to the central pain sensitization, increased the response of the neuron following normally non-painful, often repetitive and stimulation. While another important terminology which is going to be used in pain is a primary hyperalgesia, which is result from the direct effect of injury to the skin or nerve tissue. Hyperalgesia means overreactive to the pain stimulation. An increased response to the stimulus that is normally painful at the site of the injury or inflammation. While secondary hyperalgesia involves the increase in the pain sensitivity of the surrounding tissue. So what I'm going to be understanding from this terminology? I'm going to understand that there is an stimulation and there is a response inside the tissue. And there was a different modality of a stimulation and a different response of the tissue. The tissue is going to be response in the following: either allodynia, that is to say, the injured region became sensitive even when there is a light touch or a light stimulation, while the primary hyperalgesia, when there is a direct effect of injury to the skin and the nerval tissue, there will be overreactive. So sometimes they will be overreactive in the area, or sometimes the pain sensitivity is going to be occur in the surrounding area of a stimulation also. That is what we call it the secondary hyperalgesia. Again, we have to know the four phases of the pain pathway, as we are going to see: the transduction, the conduction, the transmission, modulation, the perception, and we are going to have some idea about each one of the following. So let us go to understand what's going to be happening when there is any stimulation to the area and how the response is going to be. Transduction begins, as a general talking, when the peripheral terminal of fibers, nociceptives as C fibers and L delta fibers, are depolarized by noxes, whether it was mechanical, thermal, energy. And here we are going, in this diagram, we are going to understand how the message is going to be produced. So this is what we call it the spinal cord, and this is what we call it the brain. And exactly there will be an area which is going to be transmission. These impulses from the spinal cord to the brain. And this is usually occurred by the spinothalamic tract, through the dorsal column, and it is going to be passed into anterior corticospinal tract, as we are going to see. And again, there will be transmission also by the interior corticospinal tract, which is going to be received by the thalamus, the cerebral cortex, and this area is responsible about the processes of the message which is going to be transmitted from the spinal cord to the brain. This is what we call it the transduction. Spinal cord is going to give a message to the brain through the interior corticospinal tract, lateral corticospinal tract, and this message is going to be received by the brain into most important area, the thalamus, the cerebral cortex. These two areas is responsible about the processes of the messages which is going to be passed to it through these canals. So the most important things, as we are going to see in this diagram, when there was any injuries is going to be applied on the tissue. This is the tissue and this is the source of injury. Whatever this source of injury, whether it was chemical, mechanical, or trauma, whatever, there will be chemical mediators is going to be initiating. And these chemical mediators is going to be acting in two ways. Histamine, the bradykinin, the prostaglandin, the area surrounding the functional pain unit. But as a part of a body defense mechanism, it is going to be produce natural painkiller. So these chemical mediators, as I've showed, is going to be divided into two actions. The histamine, the bradykinin, and prostaglandin in the area surrounding the functional pain unit, while the body as a types of physiological reaction is going to be produced. The most important, natural painkiller. This natural painkiller is going to be act to two ways, as we are going to see. Enkephaline is going to be block pain signals in the spinal cord, while another painkiller which is going to be producing by the body is called the endorphin. And these substance or these mediators is going to be block pain principally when it is going to be reach the brain stream. So the painkiller is going to be divided into two area of action. One of them is going to be occur at the spinal cord. The other it is going to be occur at the brain stem. And both is considered to be as a morphine-like substance. And the action of these two important chemical mediators is similar to the medication or similar to the drugs which is going to be given to the patient. Again, injury of the tissue, chemical mediators is going to be produced. Some of them is going to be initiating the pain. The other is considered to be as a painkiller. One of them is going to be acting on the spinal cord. The other is going to be acting on the brain. Review that. We have to know the onset, the localization, the characteristic, the course of the pain, and what are there is a factors that is alter the pain or if there is any associated finding. All of the above mentioned will be help me in order to make the accurate diagnosis of the pain. As a result, I'm going to direct the patient to the required treatment for each types of. Knowing the anatomy is very important during dealing with the types of pain. Knowing the area which is going to be supplied by the face or another area which is going in which the patient is going to be complained is very important during investigation the different types of pain. And here we have to know that the trigeminal nerve, which may be associated with the trigeminal neuralgia, is the dominant nerve that replies sensory impulses from the orofacial area to the central nerve system. Further information is required by us to know the facial nerve, as we are going to see here the different branches of the facial nerve, whether it was temporal, digomal, buccal, marginal, cervical, the glossopharyngeal nerve, the vagus nerve, and even though the upper cervical nerves, C2 and C3, which is considered to be as a sensory information from the face and the surrounding area. In terms of nexus stimulation, some are unimodals and respond only to thermal or mechanical stimulation. Others are considered as polymodals and are going to respond to mechanical, thermal, chemical, whatever. And the most important things is the nociceptors, called the intensity, the duration, the quality, and the nexus stimulation of this nexus stimulation. So knowing the anatomy is very important. Knowing the area which is going to be supplied by the trigeminal nerve or supplied by the facial nerve is very important in order to make an accurate diagnosis to the patient. So how we could make a differential diagnosis of the orofacial pain? Most important things is to know whether the pain is may associated from intracranial pain disorder, like for example, the neoplasm, aneurysm, abscess, hemorrhage, hematoma, edema, or whether these types of pain is considered to be as a primary headache disorder. That is to say, vascular types of pain or neurovascular types of pain, like for example, migraine, the cluster type, paroxysmal hemicrania, cranial arteritis, and the tension types of headache. neurological types of pain, trigeminal neuralgia, glossopharyngeal neuralgia, even there's occipital neuralgia, there is another source. Continuous pain disorder, neuritis, post-herpetic neuralgia, post-traumatic, and post-surgical. Intraoral, which is considered to be as the odontogenic type of pain. And this is mostly associated with the dental pulp, periodontitis, mucogingival area, or even from the tongue. The temporomandible joint disorder, as we have been seeing the lecture regarding the temporomandible joint, whether it was disc displacement with reduction, disc displacement without reduction, or whether it was associated with the muscular types of pain, or whether it is associated with bone degenerative changes. Associated structures, like for example the ear, the eye, the nose, the paranasal sinus, throat, lymph node, and so on. So knowing these characteristic features of every type of pain is very important in order to make a diagnosis. But as a general talking, and unfortunately, the, the these types of pain is not going to be occur separately. That is to say, differentiation of these types of pain is not so easy. Here we could demonstrate it in case of intracranial pain, more than one division is going to be involved. Therefore, there will be increase in the intracranial pressure. If the cause is intracerebral, then there may be neurological deficiency or could be easily demonstrated in those types of patients. It is considered to be the most important clinical features if the patient is complaining from intracranial lesions or intracranial types of pain. Here the patient may attending to you may complaining from headache, and if you further investigating these types of patient, we could demonstrating that there will be impairment in the conscious of the patient. Sometimes we could develop the papilledemia, again, nausea, vomiting, and if you are going to be measure the patient blood pressure, we could demonstrating that the patient may complaining from raise in the arterial blood pressure. In addition to the body cardia. The most important things is the conscious level and the papilledemia, which is considered to be is an optic disc swelling, and this is mostly occurred due to the increase in the intracranial pressure, sometimes due to many causes. The swelling is usually bilateral and can occur after hours or weeks, and sometimes it is going to be representing as unilateral, which is considered to be as very rare. And here, fundoscopy is recommended in order to make a diagnosis, and further investigation, like for example the CT and MRI of the brain, is very important in order to know or in order to measure the optic nerve sheath diameter for detection of the increase in the intracranial pressure. Brain swelling can be caused by numbers of injuries. Traumatic injury to the head, or not having enough red blood cells or hemoglobin, that is to say in anemia, or sometimes cerebrospinal fluid is going to be occur what we call it hydrocephalus. So what is the mean of the hydrocephalus? Hydrocephalus is a condition in which an accumulation of cerebrospinal fluid occur within the brain. And increase of the cerebral spinal fluid inside the brain may cause increase in the pressure inside the skull, and those types of patients may complaining from double vision, poor balance, even though they may complain from other characteristic features, like for example, the mental impairments, the personality changes, even the urinary incontinence of those types of patients could be demonstrating. So, taking into consideration the most important clinical features of the intracranial pressure. Another thing that is related to the intracranial, whether there is encephalitis or meningitis, that is to say tissue inflammation. Again, the patient may complain from hypertension, and even though collecting of the infected pus in the brain, and here the patient may complain from abscess inside the brain. And the most important things that we have to consider is the brain tumor. Again, what we mean exactly by encephalitis is considered to be as acute inflammation or swelling of the brain. Sometimes this may occur due to the viral infection, as we are going to see, except in the current situations that we are passing through the epidemic. Sometimes it's going to be passed through the, or it's going to be passed through the brain, and the immune system is going to be mistakenly attack the brain tissue, and it is going to be developed rapidly, and actually it is required an urgent care. And the main cause is the herpes simplex sometimes, chickenpox, mumps, rhabdoviruses, and so on. So brain inflammation may occur by viral. الآن أيضا نلاحظ في هذه الأيام some of the cases of encephalitis is going to be increased. Here we are going to investigating the chronic orofacial pain, and this could be divided into the musculoskeletal types of pain or the neuropathic orofacial type of pain. The neuropathy, there will be damage or disease affecting the somatosensory nerve system, and sometimes it may associate it or not associated with a dysesthesia or pain from the normally or non-painful stimulation, the allodynia. Sometimes it is considered to be as continuous or episodic. So let's have some idea about the neuropathy of the orofacial pain, which is going to be divided into the following. Either the patient may complain from trigeminal neuralgia, glossopharyngeal, ankylate neuralgia, post-traumatic neuropathy, and the most important things in most of the cases that is attending to our departments, burning mouth, facial post-herpetic neuropathy, and the central post-tract pain. Again, these are considered to be as the neurofacial neuropathic types of pain. Knowing the characteristic features of every types of these neuropathy of pain, knowing the onset, how the pain is going to be represented, what are the characteristic features, is very important in order to differentiate, in order to knowing how we are going to deal with these types of patients. And This is the main aim of this lecture. Another source of pain is considered to be as a neurovascular types of pain. Neurovascular types of pain often associated with headache and here associated with a pain disorder that are felt as cephalus or pain in the head. It is considered to be as a heterogeneous group of disorder and it is going to be affected common anatomical region of presentation. Neurovascular types of pain are currently viewed as arising from the neural firing of nociceptors associated with intracranial blood vessels and dura. ولهذا السبب, for this reason, this is going to be referred to the vascular types of pain. Further research has identified both peripheral and central aspects of the nerve system as playing a role in the initiating and the perturbating of the pain. Here we could demonstrating cluster headache, migraine, the paroxysmals, cranial arteries, potential types of headache. So knowing the characteristic features of every types of pain that we're enumerating here is very important in order to differentiate, in order to make diagnosis. Here we are going to have some idea about neurology. So, what is a neuralgia? Neuralgia is considered to be as a stabbing or burning or even severe types of pain, which is considered to be as irritating or damage of the nerve. This nerve can be occur in any part of the body. In the classical neuralgia that affect the craniofacial region are unique group of a neurological disorder involving the cranial nerves and are characteristic by brief episodes, trigger zone on the skin on the mucosa, and the pain-free period between the attack and between the refractory period. Immediately after an attack, during which the new episode cannot be triggered. So these are the main important characteristic features. Again, a gamma view is considered to be as a brief associated with the trigger zone and refractory period. And sometimes the aging, and there is a specific types of disease, like for example the diabetic or multiple sclerosis types of pain. So today we are going to start with the trigeminal neuralgia. Trigeminal neuralgia, the most common types of the neurological types of disease that is attending to the dentist. And we could see that there are many cases attending to us and they are complaining from trigeminal neuralgia, but actually or unfortunately they have been not diagnosed. And most of the dentists they seen or they thought that the main cause was related to the odontogenic source of pain. And they starting making different modalities of odontogenic types of treatment, like for example filling, root canal, and even though they make extraction to the many multiple teeth. After that, the patient attending us and still the pain is going to be persist. By further investigation of the cases, we could demonstrate it that the pain is not related to the teeth, not related to the periodontal area. Actually, it is related to the neurological types of pain. So how we could know that? And how we could make the accurate diagnosis of those types of patients and how we are going to manage. So let me know that a severe recurrent shooting patient, if the patient may attending to us may complaining from sharp stabbing, The most important things is the electrical lasting. And this is usually occur within second. Sometimes it may occur within a minute. And it is going to be provoked by talking, eating, or even when you are going to touch a specific area. This specific area when it's going to be touched and is going to be initiating the pain is considered to be as a trigger zone. And shortly lasting, and it is mostly unilateral. Another characteristic features is severe paroxysmal pain in one of the branches of the trigeminal nerve, which is the ophthalmic, the maxillary, and the mandible. People who is going to be affected mostly occur at the middle age or elderly type of people. And most of the studies they have been confirmed that female is affected more than men, male more than male. The most common side which is going to be involved is the area which is going to be supplied by the mandible nerve and the mandible mental area, or the maxillary area in which the maxillary canine area is mostly involved. We have to put in mind that the ophthalmic distribution of a trigeminal nerve is rarely is going to be infected. And most important things, there will be period of remission, but the condition is going to be reoccur or persisting through the patient life. Trigeminal neuralgia is characterized by spontaneous remission lasting weeks to years, but approximately 20% of the patient may complaining from daily attacks. So again, I'm going to summarize the characteristic features of these types of pain is the electrical lag shock. Second, the trigger zone, which is going to be occur. Third, refractory period, which is going to be occur, and the anatomical consideration by which area is going to be supplied, whether it was a maxilla or whether it was a mandible nerve, in which the mandible mental area is going to be affected in addition to the maxillary canine area. Latency refers to the short period of time between the stimulation and the pain onset. So this is what we exactly refer by the latency, while the refractory period is a care following an attack. In this, during this period, during the refractory, even when there is any stimulation, it occurred to the area which is complaining from the pain could not be initiating. So please, when you are going to investigating these types of patients, try to differentiate between the latency and between the refractory period. Here we have to know that the duration of the pain sometimes is may extend from seconds or even though 2 minutes. But whatever the duration of the disease is going to be occur within the patient is going to be have a longer duration in attack. That is to say, the patient complaining from trigeminal neuralgia for a long period of time, from a years, for example, if we are going to ask these types of patient, we could report it or demonstrating that the disease duration is going to be increased. The most paroxysms occur during waking hours, but in a rare cases, during taking history, we could demonstrating that the patient may wake from his sleep and mostly associated by spasms of the ipsilateral facial muscles. Hence, the name is tic thorax. So, during investigation, I'm going to repeat, try to differentiate between the latency, the refractory period, and the duration of attack taking into consideration the duration of the patient have been affected by the trigeminal neuralgia is going to be affected the longer of the attack. So what are the etiology of these types of pain? Most of the cases, we could not demonstrating any etiological factors which are associated with these types of pain. But studies have been showed only in small numbers of patients, we could demonstrating that there is intracranial lesion, like for example, tumor of the cerebral-pontine angle, demyelinating of the which is occur in the multiple sclerosis in MS. In rare cases, a vascular malformation may be taken into consideration, and mostly other cases is considered to be as idiopathic. We could not demonstrating any etiological factors. Sometimes the atherosclerotic blood vessels and specify the superior cerebral artery could be demonstrating, and here there will be pressing on and the growing of the root of the trigeminal nerve. As a result of these types of pressure, which may occur by the atherosclerotic blood vessels, we could demonstrating the presence of the demyelinating. Demyelinating mean that the myelinating sheath of the nerve fiber is going to be removed, and it is going to be more thin. And as a result, there will be hyperexcitability of the nerve fiber, which will then fire a response to even a very light touch, and resulting in a brief episodes of intense pain. These are the common etiological factors. And I could summarize the etiological factors whether it was 90 or 80% it is idiopathic, and we could not know the exact etiology of it, but sometimes during investigation we could know that there is another causes which is responsible to develop the trigeminal neuralgia. Some of this may relate to the systemic disease, like for example the MS. Some of them may relate to the vascular malformation or the atherosclerotic of the blood vessels. Please try to take care regarding this condition, which is considered to be as a pre-trigeminal neuralgia. Here, an early form of a trigeminal neuralgia termed pre-trigeminal neuralgia has been reported in some cases of a trigeminal neuralgia, and here the patient is complaining from dark continuous types of pain. These types of pain may occur in one of the jaw. It is going to be persisting for a long period of time before it is going to give the characteristic features of the trigeminal neuralgia, like for example, the electrical-like action. In these, when we are going to apply any thermal stimulation, this may cause a triggering these types of pain, the throbbing equality, trigeminal neuralgia pain. Sometimes it is highly similar to the dental or to the odontogenic types of pain. But by using a specific type of anesthesia, we have sometimes misdiagnosed and considered to be as odontogenic types of pain or dental in origin. Again, these types of pain is highly response to the carbamazepam, and careful dental assessment should be held in order to differentiate it. So pre-trigeminal neuralgia, sometimes it's misdiagnosed as a dental type more than trigeminal neuralgia. So how we could make a diagnosis of that? Diagnosis is usually based on the following. First of all, it depends on the history from the patient, the anatomical distribution of the nerve of the pain along the trigeminal nerve, the trigger zone, and the precipitating of the pain is may occur when there is any touch in this area. And here we could demonstrating the shooting type of pain. Again, most important things is the MRI of the brain in order to rule out any tumor. So any patient who is complaining from electrical like inactivity or shooting types of pain, in which may occur along the distribution of the nerve without any odontogenic source of type of pain, we have to send the patient of the MRI or the magnetic resonance imaging. This is very important in order to exclude any intracranial lesion, any vascular malformation. The way that we could make a diagnosis either by medication, and here the Tigritol is considered to be as a drug of choice. The initial low dose therapy is starting with a 100 milligram, and sometimes we are going to increase the dose, and sometimes even though we are going to reach 800 milligram per a day, after that we are going to continue tapering the dose or titration the final dose, and this depends how we are going to respond and the side effect of the medication. Taken into consideration that those types of patients may complaining from light headache, confusion, dizziness, vertigo, blurred vision, diplopia, sedation, vomiting, nystagmus, which is considered to be as the most common of the patient. So when we are going to prescribe these types of medication to the patient, what we are going to do, what is the specific precaution when I'm going to deal with these types of patient who is already taking this medication, taking into consideration that complete blood pictures or hematological laboratory is recommended. Hematology, complete blood picture, differential cell count, and even though we have to investigating the liver function test, maintaining the hepatic, like for example the alkaline phosphatase, the bilirubin level, the SGOT, the SGPT. Another important recommended investigation for those types of patients who are under treatment for a long period of time is knowing the renal function test, which is considered to be as recommended. And here we have to investigating about the blood urea nitrogen, creatinine, albumin, protein level, and other function of the kidney should be established. Sometimes the patient does not respond to the carbamazepine, even when we are going to increase the level of these types of medication. Sometimes we're going to use a combination which have a strong synergistic effect with the carbamazepine, and this is what we call it the baclofen, which is considered to be as a muscle relaxer. Newer anticonvulsants, but fewer side effects that have been shown to be effective in some cases. Other types of medication, the gabapentin, which is very important in addition to the lampothrigine. These types of medication is important in a selected cases of trigeminal neuralgia. If the patient do not respond, sometimes you are going to use a combination types of medication. Another way to deal with these types of patient, if we do not respond to the medical, sometimes we are going to refer the patient for a neurosurgeon for the surgical, peripherally or centrally at the trigeminal ganglia on the nerve root. In the surgical procedure, even it is considered to be as a very complicated, a very serious condition, but might have a better prognosis when carried out with a patient with a typical trigeminal neuralgia. Peripheral procedures, peripheral neurectomy sometimes. There is the dangers of including traumatic neuropathy pain, and it is not recommended always. Now, the modern ways of treatment is by use the cryotherapy of the peripheral branch. This may give pain relief for 6 months. The pain reoccurrence is at the original site. Repeated cryotherapy often produces better results. So I'm going to summarize the type of a treatment either by medication or by surgery or by cryotherapy. Surgery, sometimes even peripheral neurectomy. It is considered to be as a very serious, even though the traumatic neuropathy pain, and it is not recommended. Another way to make a diagnosis is by alcohol injection. But this types of method is considered to be as a very powerful. Here we are going to be injected the alcohol in the trigeminal nerve in the ganglia in this area. Sometimes it may associate it with the fibrosis. Sometimes it may induce herpes zoster reactivation, even though bone necrosis have been demonstrated in specific cases, in a very rare cases. The pain control after alcohol just sometimes persisting for 1 year, and sometimes it may associate it with post-injection in neuropathy types of pain. Please try to be here regarding dealing with these types of treatment and try carefully to explain to the patient the possible complications that may associate it with this method. Sometimes they are using glycerol injection, and these are the most common complications which may associate it with this method. Headache, ocular anesthesia, masseter weakness, hyperalgesia. Another neurology that we are going to investigating is the glossopharyngeal neuralgia. Here, the glossopharyngeal neuralgia is different from trigeminal neuralgia regarding the location of the trigger zone or the pain sensation along the distribution of the glossopharyngeal neuralgia. That is to say, the area which is going to be involved is the pharynx, the posterior tongue, the ear, and the intra-auricular area. And if we are going to take a history from the patient, we could see that these types of pain persisting for a long period of time. It is very difficult to be diagnosed. Even though the treatment is very delayed for years. And sometimes when we are going to take a history also, we could see that the chewing or talking is going to be stimulating these types of pain. The application of typical anesthesia to the pharyngeal mucosa is going to be eliminate glossopharyngeal nerve pain. This could be aid in the diagnosis from other types of pain. This is the area which is going to be supplied by the trigeminal nerve, by the glossopharyngeal nerve, sorry. As we know, two main sensory branches, the auricle, tympanic, the pharyngeal. So we are going to divide it, the glossopharyngeal nerve, into two types of pain. The pharyngeal, the glossopharyngeal, the pharynx, the posterior tongue are going to be involved. And sometimes the pain is going to be extended to the air, to the angle of the mandible, even though the eye, the nausea, the maxilla, and the shoulder even is going to be involved, and even the tip of the tongue also. While in tympanic branch, pain predominates in the ear, but sometimes it's going to be relating to the pharynx also. We could demonstrating that bilateral pain occur in up to quarters of the patient. The glossopharyngeal neuralgia is a paroxysmal unilateral severe pain that is considered to be as a sharp, stabbing types of pain, shooting types of pain, or lanceting. Here the patient is often feel a scratching or a foreign body sensation in his throat, as we are going to see that the pain is going to be extended into the throat. Pain intensity is usually milder than trigeminal neuralgia, but may vary. Attack lasts from fraction of second up to 2 minutes. So here we could differentiate the area which is going to be supplied by these types of nerve, which is affected by pain, and the characteristic features of the pain, which is considered to be either sharp, stabbing, shooting, or lanceting. And if you are going to ask the patient, we could see that these types of pain persisting for a longer period of time before its diagnosis, and sometimes even talking or swallowing may initiating these types of pain, and the pain may complaining from foreign body, or he'd complain that there is a sensation in the throat. Look here, I'm summarizing the characteristic features of these types of pain. The trigger area are located in the tonsil region, posterior pharynx, as I've said, and also a refractory period. Swallowing could be initiating these types of pain. Even coughing, sneezing, all of this could be here. Taken into consideration that the frequency is about 5 to 12 every year, and attack may occur in a cluster lasting week, the numbers of years. Spontaneous remission occur in the majority of the patients. Glossopharyngeal neuralgia may induce uncontractable coughing, seizures, cardiac arrhythmia. Look, these types of patients may complain from seizures attack, and sometimes during investigation, heart problems. That is to say, the patient complaining from bradycardia and syncope. And here we have to investigating the patient for CT and MRI also. The MRI is considered to be as very important, and the angiography is considered to be the most characteristic features, and here we could identify that there is a neurovascular compression. What are the pathologies? Again, we could demonstrating that it may associate it with a multiple sclerosis, even inflammatory process or tonsil carcinoma. And the other things that is considered to be important and a serious condition and further investigation is recommended is whether there was a regional tumor which is here along the distribution of the nerve. That is to say, the patient may complain from tongue or oropharyngeal. Another thing is cerebral-pontine angle tumor, which is considered one of the pathologies of the glossopharyngeal neuralgia. Again, the same will apply for the glossopharyngeal neuralgia. The exact pathophysiology is not know, it's not well understood, but sometimes it may be associated with a compression of the nerve root by blood vessels. And MRI recommended in order to demonstrating if there is any nerve compression. And if we are going to take a biopsy from the nerve, we could see that their myelin layers is going to be have a damage. And we could demonstrating that there was a demyelinated axon. That is to say, the myelinating sheath is not going to be represented, so this nerve is going to be sensitive to any little touch or little pressure is going to be applied it. The same morphological changes could be demonstrated by trigeminal neuralgia also. The treatment, we start with the carbamazepam, the same for the trigeminal neuralgia, and sometimes we need a combination types of the therapy. We need a muscle relaxant, like for example the baclofen. The same like the trigeminal neuralgia types of treatment, as I say, the gabapentin, the alarm triggers, and the phenytoin is recommended also. That's what we call it. Another type of pain, the acute herpes zoster. Most important characteristic features associated with these types of pain. It is occur along the distribution of the nerve, unilateral and associated types of pain. The facial pain associated with herpes zoster, post-herpetic neuralgia, acute herpes zoster, and here there will be reactivation of the latent varicella virus infection, which is usually occur after the primary infection of the herpes, and considered to be as a disease of a dorsal root ganglia. And we could demonstrating that there was a vascular eruptions along the dermatological area, which is going to be affected by the acute herpes zoster. At acute diagnosis, we could identify the viral DNA from the vascular fluid, and we are going to use a PCR, the polymerase chain reaction, and taking into consideration that the trigeminal and the cervical nerve are involved in a quarter of the cases. The ophthalmic branch is affected more than 80% of the trigeminal cases. As we know, the trigeminal is going to be divided into ophthalmic, the maxilla, and the mandible. In elderly people, the trigeminal nerve is mostly affected, and it may associate it with a vascular eruption, the sight-threatening keratitis. The vesicles and pain are dermatol and unilateral and may appear intraorally. When the maxilla, the mandible branch is going to be affected. So we could demonstrating the presence of a multiple vesicles eruption, like eruption on the oral mucosa. In cases of herpes zoster infection, the maxillary and the mandible branch of the trigeminal nerve is going to be affected. So we are going to have an idea about the etiology, the pathogenesis of these types of pain. As we know, the herpes zoster is going to be caused by reactivation of the latent varicella zoster virus, which is going to be result in a pain and vascular lesion along the course of the affected nerve. Majority of the cases of herpes zoster is going to be resolved within a month after the lesion healed. But there are cases in which we could demonstrating that the pain is persisting longer than month. And here we could classify that the post-herpetic neuralgia. And some authors do not make the diagnosis of the post-herpetic neuralgia until the. So let's have some idea about the clinical features. Usually begins with a prodrome of regional pain, itching, melissia, pain preceding typical vascular eruption by less than 7 days, usually 2 to 3 days. And here we could demonstrating the presence of the vascular and herpetic eruption. There will be rupture and dry out over 10 days, but completely healing may last up to 1 month. Accompanying pain is moderate to severe, visible and a log scale is about 6 and may persisting of 3 to 6 months. Very rarely dermatology or dermatol pain care with no rash. Again, we are going to have some idea about the treatment of the shingles. So our main aim in treatment is going to be directed for controlling pain and try to accelerating the healing. And as a general token, we try to reduce the risk of complication. The most important risk of the complication is the meningitis, the post-herpetic neuropathy, and sometimes there will be local secondary infection. Therefore, when I'm going to deal with these types of patient, I have to start with the antiviral types of medication. And this should be initiated within 72 hours from onset of rash, taking into consideration that people age more than 50 years old is very important to start with them, the antiviral, and this is considered to be as a particularly effective in those types of patients. Other complications that may associated with this infection, shingles, those types of patients may complain from fever, pain, and this fever and pain should be controlled by analgesic, and the central analgesic should be recommended. Anyhow, there are many research concerning about the use of the glycocorticosteroid. Till now, it is considered to be as a controversial, but this corticosteroid may be used to reduce the acute pain and also imitriptyline may reduce the incidence of the post-herpetic neuralgia. Vaccinating at-risk individual market reduce the incidence of post-herpetic neuralgia, and this is specified in older adults patients.